We're going to review the physical assessment of the ears. With the patient's ears, you want to get a history of any earaches, infection, discharge. If they're experiencing any hearing loss, you want to ask questions about environmental noise, which you can see here on this chart, the different noise levels. At home, on average, our noise level is about 40 decibels. But as you start to exit your home and go out into the world, these decibels will increase. Inside your car, the decibel level is about 60 to 70 decibels. With heavy traffic, if you have your air conditioner on, your windows down, perhaps hearing a lawnmower, that's at about 80 decibels. A chainsaw, leaf blower, that's nearing now over 100 decibels. And normal conversation background, going back to about 60 decibels, is still in a good range of healthy noise levels. So anything over 80 and above starts to become harmful to your ears. So you're thinking about environmental noise, what they may do for a living, and then that turns into asking questions about self-care. If they are someone that uses any of these type of equipment which will produce these noisier decibel levels, you want to make sure that they are using ear protection, or if they are someone that works outside, that they are also reducing that environmental noise, maybe by ear protection as well. And for those of us that use headphones, earphones, or anything of the like, thinking about how much exposure we have to higher decibels of sound. Tinnitus or tinnitus, this is the ringing of the ears. Sometimes this can be a rather annoying symptom. There is not much to do for this symptom, but you do want to see if it's something new. Sometimes tinnitus that is not from or related to being exposed to loud sound exposures could be a symptom of perhaps even a medication or an antibiotic. You're asking also about vertigo, and mainly because your ear not only is for sound, but there is a function for balance also. In terms of self-care, we talked about ear protection, but also you want to ask them what their routine is for cleaning their ears, and if there's someone that uses ear swabs to go in and clean earwax. This could create more damage and push earwax's rumen further into the canal. For your ear exam, you can use an otoscope, but this is more for advanced clinicians. Today, we will only be using our pen light to look at the external structures and testing for hearing. So in addition to your pen light, you do want to use a tuning fork to check for a conductive or neurosensory or sensorineural hearing loss. So first thing you're going to do, inspect and you're palpating the external structures. You're looking at the size and shape of the ear, the position of the ear in relationship to the rest of the face, and bilaterally symmetrical to the other ear. You're looking at the skin, noting any abrasions or skin conditions that may be present on the ear. Asking your patient if there's any tenderness in the external and the internal area, or internal ear, but the external canal. When you're looking at the external canal, you're checking the color, you're looking for any swelling, lesions, or discharge. With the otoscope, you would be able to see the tympanic membrane, and you would look for a color that is what we call pearly gray, which is depicted here. You're checking to see that the cone of light is being reflected. Sometimes when the ear is bulging or there's fluid behind or there's an ear infection, you're not able to see this cone of light. The cone of light also tells me what ear I'm looking at. When I see the cone of light at a 5 o'clock angle, I know that I'm looking at the right ear versus a left cone of light would be at 7 o'clock would be left ear. I do want you to play this on your own slides, the difference between the Weber and Rhines test. And this is a test that you would do after testing for the whispered word test, which is the physical exam test for hearing, where you stand behind your patient about 12 inches, having your patient close the opposite ear, and you are whispering a 2 to 3 word phrase or word. I usually like to use number and letter combinations, like I'll use like A7, 6. I try to not use letters that sound the same, like B and P, things that can be confused. Or you can simply say a 2 letter number, or two digit number like 27, 79, 64, something like that. And so you'll test each ear separately. You're testing first one ear with the opposite ear closed, and then move over to the other side of your patient and doing the same. Now going back to the Weber's and Rhines test, once you have tested that whispered voice test or whispered word test, you're going to use the tuning fork test only if they fail. If you use the tuning fork, the first one you will use always is the Weber's test first. You're going to strike that tuning fork and place it on the middle of their forehead, about the hairline. And normally that lateralization or that feeling of vibration from the Weber's test should be felt equally in both ears. Now, if it lateralizes or can only be heard or felt one ear over the other, if it lateralizes, let's say to the right ear, then that would suggest that there's conductive loss of that right ear, but it also could mean that there's sensorineural hearing loss on the opposite ear. And so because this Weber's test is inconclusive, you have to move on to the Rhines test. And the Rhines test, you're striking that tuning fork again, but you're going to first place it on the bone or mastoid bone behind the ear and ask them if they can. There's 2 ways to do this. You ask them if they can hear it, and then once they hear it, you put it in front of their ear, and if they hear it louder, then air conduction is greater than bone conduction. You can also do it by first placing on the mastoid bone and waiting for that vibration to end, or that feeling of the vibration to end on the mastoid bone, and then you move it to in front of the ear. And if they can still hear it or sense that vibration, then air conduction is greater than bone conduction, which you can see here, AC greater than BC is the normal finding. So if you have a Weber's test that lateralized to the right ear, but the Rhines test of that ear and opposite ear is normal, then you can conclude that this patient has conductive hearing loss of that ear. But if you do the Rhines test of the left ear and BC is greater than AC, then they have sensorineural hearing loss of the left ear. So this tells you that Weber's test is not conclusive. It just tells you either or, and you have to do the Rhines test to confirm. You can also test the vestibular apparatus that tests for balance. Remember again that your ear also is a function of balance. By testing the Romberg's test, which we'll see more when we do the full neuro exam, but if your patient is able to stand with their arms to their side with their eyes closed for 30 seconds without swaying, this is a Romberg's test, and they can demonstrate that they have balance. You can also have them put their arms forward like a zombie walk, with their eyes closed, and still in one position, standing straight for about 30 seconds, and they should be able to maintain balance. So that is the vestibular apparatus test of the ear. This slide, not that I want you to memorize it all, but I just want you to be familiar with what charting might look like for a Rhines and Weber's test. And you can see the different hertz that was used for the Rhines test and the different findings. AD versus AS, oris dextra, oris meaning ear. Dextra is a Latin term that refers to the right ear, and sinistra is the Latin term that refers to the left ear. So some abnormal findings for the tuning fork test. If you note that there is conductive hearing loss by doing the Weber's and the Rhines test, then there could be a mechanical dysfunction of the ear, or there's some type of foreign object in the ear. So let's say someone has impacted earwax or cerumen, or there's a crayon inside the external canal, then the conductive hearing loss is going to have a deficit because there's something within that canal. There's a mechanical dysfunction. Central neural hearing loss has to do with the inner ear or cranial nerve 8 specifically, and presbycusis, which occurs naturally with aging as we start to lose some of our hearing, is a deficit of central neural hearing loss. And then some type of ototoxic drugs that affect the hair cells in the cochlea of our ear, perhaps certain antibiotics actually, will cause some central neural hearing loss. And some people will have a mixed hearing loss of conductive and central neural. And I would recommend you clicking on the link below and watching an audiologist briefly talk about the difference between conductive versus central neural hearing loss.